becoming even more common as the common public do more sport, involves more sport and running. If clinically unstable, it necessitates surgical reconstruction. The ACL graft femoral fixation methods, either using aperture fixation or cortical fixation like endobutton or transfemoral fixation, which I'm talking about today. The transfemoral fixation methods could be bone mulch screw or transfix pin or semi-toggle fixation like rigid fix femoral cross pins. The advantages of the transfix pins, they can be metal, titanium, or bioabsorbable. The advantages of the PLLA, they give undistorted images on the MRI scan and does not compromise your revision surgery because they are absorbed with time. I'm just giving a short video about the technique if people are not familiar with it. This is the U device was passed through the femoral and tibial tunnel. And one case of kinked and broken passing wire following ACL reconstruction using the PLLA implant. The first patient had revision ACL reconstruction and the wire twisted while putting the implant. At 8 weeks, he developed lateral knee pain with localized swelling. Clinically, he had iliotibial band friction syndrome, and that confirmed with the MRI scan. I removed the implant, could not remove the wire, cut it flush with the bone, and the patient was symptoms-free at 6 weeks. The second patient had primary ACL reconstruction, and again developed iliotibial band friction syndrome at 8 weeks, post-operatively, confirmed by the scan, and you can see the head of the implant just protruding through the lateral cortex with localized edema and fluid collection. The implant was removed, and the patient again symptoms settled. The third patient had moderate lateral knee pain at 12 weeks, and again you can see it's just a slight protruding of the lateral end of the implant with localized swelling. I did not remove the pain and eventually settled because I didn't think that is too much protrusion there. The possible causes of lateral protrusion of the femoral implant are either technical due to failure of the site properly intraoperatively, or blowout of the posterior cortex, or two oblique pin placement causing a slip of the pin. None of these happened in the 3 cases. Alternatively, there could be material degradation of the implant, but that happens about 2 to 5 years later on, and these patient's symptoms appear a few weeks after the operation. I propose that's the deformation of the implant that leads to migration, and it is possible that aggressive early rehabilitation can overload the implant, leading to deformation and lateral slip. Some useful technical tips: pull simultaneously and evenly on the 2 ends of the passing wire as the graft is advanced into the femoral socket and maintain the traction on the wire ends. That's to avoid really kinking of the wire. If the wire is kinked, stop pulling the graft into the femoral canal and try to remove it and replace it with a new one. You always do this under supervision arthroscopically. When you hammer it, hammer gently and ensure that the final depth of the impactor, as I showed in the video, have the same marking as the approach drill did. Carefully palpate the lateral cortex and make a larger incision if necessary to palpate and feel the end of the pin. Thank you for your attention.
Thank you very much for a nice presentation. I have a question for the case number 2 that you show that you removed the pin at 8 weeks after surgery, right?
No, I didn't remove after 8. He had symptoms after 8 weeks. We know that actually, well, the vast majority of the graft is taken into the bone at 8 weeks. I waited about 12 weeks and then I took the pin, and it was very
So you wait for 12 weeks after surgery
and
remove the pin.
Months or so, yeah.
And how about the rehabilitation program?
I carried on with the rehabilitation.
But
I don't allow them to run on a treadmill for 3 months anyway. So initially I'll just allow full movement, control of pain, quadriceps and hamstring exercises.
Okay, thank you.